think we're good.
Okay. Yeah, I'll give a brief introduction, but Dr. Ensari can give more. I mean, this is very impressive. She has very impressive research, so she can talk more about research. But again, welcome, Dr. Ensari, to our speaker series, speaker series at Data Science and Analytics Master's program here at Georgetown. We really appreciate your time in being here. So, Dr. Ensari is an assistant professor in, again, I'm sorry if I'm mispronouncing any of these words. In Windreich Department of AI, like Artificial Intelligence and Human Health at, I want to say, Icahn School of Medicine and Hasso Plattner Institute for Digital Health at Mount Sinai. So she has a lot of great research background, and I think she would be talking a lot about that on health and also NLP realm and machine learning. So and also she's currently leading an NIH-funded study also. So welcome again, and uh, please give us a little bit of background of your research. We would be really interested to hear more. Thank you.
Yeah, absolutely. Thank you, Dr. Parna, for that wonderful introduction, and thank you both for inviting me. So let me share my, okay, so we'll do presenter view. Okay, so I'm hoping everyone can see my,
We can.
okay, wonderful. So thank you everyone and let me know if anyone has any issues hearing me at any point, but it looks like the audio is working. So first things first, no financial or other conflicts of interest to disclose. As Dr. Parna mentioned, I'm currently primarily funded by an NIH grant, specifically from the NICHD. And the work or the data that I'll use for this talk come from that ongoing study as well, called CPP Tracker. And if you think that's a lame name, it's all my fault because I came up with those study names. So it's not the easiest thing to name in a 5-year project. And I should also acknowledge I work with a team of students and postdocs, data analysts, engineers, programmers in our lab. So it truly takes a village to do the research that we do. It's a team effort. So I'll as a group acknowledge their contributions as well. So I represent all of us when I share some of these results. Okay. Now, as you might have guessed from the title and the background, I will be, let's see, someone in chat. Oh, okay. Yes, feel free to ask. I sometimes forget to check the chat, so you can, unless it would get too chaotic, feel free to unmute yourself and ask a question. But otherwise, I did leave time at the end for questions. Anyhow, so I will focus a lot on women's health and specifically women's reproductive health, as that is a centerpiece in my day-to-day research. So this is, this topic is just another Friday for me, but it might not be the case for you. So let's first start by motivating this clinical scenario as to why we care to focus on these conditions. Oops. Okay. Now, what are these conditions? So female chronic pelvic pain disorders are a cluster of conditions that include things like endometriosis, adenomyosis, uterine fibroids, and so forth. We don't need to get into the nitty-gritty details, but for the purposes of this talk, some of the things that you should know is that they are highly prevalent around the world. And they're associated with high impact both at the individual and societal level. This is because they are associated with a variety of comorbidities, not just other physical conditions, but also other mental outcomes like depressive and anxiety, symptoms and clinical disorders of these symptoms, as well as excess healthcare expenditure. So they become costly. And they are among some of the most impactful chronic conditions worldwide. So there's quite a bit of burden of disease here. And we have been aware of this impact and these problems and the existence of this overall problem for quite a while. So it's not a new thing that we just recently discovered. And despite knowing about all of these problems, we have done a very poor job of improving how we diagnose and how we treat, and overall how to help patients who have these diagnoses, these conditions. Oftentimes, the medications are insufficiently effective, and if over time, consistently, the patients don't respond to medications, for example, physicians tend to resort to things like hysterectomies or other more serious surgeries. And as you can imagine, that's quite a drastic lifestyle change. So we want to be able to intervene long before to help these individuals. And you might be wondering why, despite knowing about these conditions for so long, that we have done such a poor job of treating and diagnosing, is because we have a very poor understanding of these conditions. There are so many unknowns, and the part of the reason, or one of the primary reasons, is they are very poorly documented or underdocumented in the standard clinical data sources that are used for research as well as clinical decision making, namely the electronic health records. And this is a problem because still to this day, even though this is expanding, EHRs do constitute among the primary data source that we use for these purposes. So we need to do a better job to address these gaps in data documentation, because that is the starting point. If we can understand these conditions better, then we can start to, better phenotype, better characterize, better monitor the patients, come out with better diagnostic approaches than, invasive surgeries, which currently is the only way to get an official diagnosis for endometriosis, for example. You have to have laparoscopy, and then better treat and better monitor. So all of these can improve if we start with improving how we document, so augmenting the data sources. So how do we do that? So enter into the scene mobile and digital health technologies. And I'm sure if you have spent any time on LinkedIn or other similar social media or news, this should not come as a news to you. We're increasingly excited about the potential of patient-generated health data via mobile health technologies. So this could be data from, wearables and sensors, so passively collected data. It can also constitute actively tracked patient data on things like symptoms, health behaviors, or what have you, anything you want the patient to actively track through smartphone apps, for example. And we increasingly have high quality, research-based apps that we use for this purpose. Now we have these technologies, or data from these technologies, can complement classical data sources, i.e. EHRs, and they have some additional advantages, such as they allow us to do prospective real-time data collection, which you typically don't get to do if you're relying on EHR data. There's some evidence that they can improve patient engagement in their healthcare, and this subsequently in the long term improves overall health outcomes. And as well, improving access to healthcare. So in addition to research, there are some other downstream effects of these technologies. In addition, more directly relevant to our purposes today, they provide us with immense data granularity, diversity, and more context with respect to how the data were collected. Some specifics to this that I should mention is, for example, they can allow us to do things like routine outcome monitoring of responses if the patient is undergoing some treatment, and this treatment can be anything. Think of it from a medication to something more behavioral, so physical therapy, or something that self-imposed or self-management, right? So these are not prescribed things, but the patient does to improve their symptoms. And this is a relevant topic because specifically for these conditions, or patients who have these conditions, self-management is a big thing, because it's very common for these individuals to not be able to find relief in the doctor's office. And so they have to take things into their own hands, and they start actually testing different things to see which works best, and they monitor. So this is a population that already uses various apps or whatever trackers to track their symptoms in response to different behaviors. Now, the other advantages, these technologies allow us to combine these actively tracked, so self-reported data with passively obtained data in sophisticated ways that can then improve our estimation, right, of the outcomes or whatever relationship that we're trying to model and estimate. So ultimately, they can help us improve how we support patients in their self-management. Now, these are all the good sides, the positives, and the exciting aspects. Now, this also means we need to be mindful about how we're integrating these data into our analyses, into our research design at each stage of the research, and also the clinical aspects that we're leading. Because these data also bring about additional considerations and unique challenges that we don't get to see, that are not inherent in other, more clinical, more standard or typical, traditional data types as well, including the EHR. So, for example, because they provide us with such granularity, that also means there's temporal complexity, right? These are data that are a lot more frequently sampled, and there's going to be variability across patients, across individuals, in terms of the time points of when a certain outcome, a certain data variable was assessed. And this matters, right? Or it can matter, it can influence your outcome. Similarly, the pattern of missingness will vary from individual to individual, from variable to variable, and again, we need to account for these. The timing of assessment can matter. So sometimes also called the critical time windows. For example, as I mentioned in my previous slide, if you're monitoring response to a long-term treatment, like let's say a 12-week medication or physical therapy or whatever, some sort of a treatment, are there certain time windows that are most critical, such as being most predictive of the outcome, the treatment outcome, that should be monitored? Versus, do you really have to monitor the full 72 days of the patient's symptoms? Like, are they all going to be signal versus how do you extract the signal from the noise? It's also important for efficiency, right? So I don't want to have to store all of those data. Now, similarly, if the whole point or one of the major points of leveraging these data is the complexity, the volume, right, the temporality and the multimodality, I don't want to just take this longitudinal data and aggregate into a summary score, which is very typical to do, right? Like if you have physical activity data, you often see in published research, they get a weekly average, weekly sum, which has its uses, of course. But there could be meaningful information in between that I also want to be able to interpret. And to be able to do that, again, I need to consider what are some of the techniques that I'm implementing, that I'm applying to these data. And as well, I alluded to, there's multimodality, right? So data from different streams, different sources. We need to think about how do we best harmonize, because right now we don't really have a standardized, universally implemented method of doing so, in addition to the summarization technique. So these are all the considerations and challenges that we also need to take into account, while also being excited about integrating these data. Now, these collectively provide the precedents for the work that we're now going to undertake together, and also the questions that keep me up at night, and my lab, hopefully, or maybe not hopefully they're not sleep deprived. So let's focus in on some of the questions that we will tackle. Specifically, I'm interested in getting a snapshot of, or sharing a snapshot of, how we can handle data from diverse mobile health sources towards better understanding day-to-day symptomatic interactions in female reproductive health or disorders, and specifically chronic pelvic pain disorders. And in addition to characterizing, I'm going to demonstrate how we can potentially look at various lifestyle habits as symptom self-management techniques. And I will focus on physical activity and its subset of exercise today. And why exercise, we'll get into it, but I think that that's an intuitive, more interpretable behavior. And I'll assume everyone is familiar with physical activity behavior. So, okay, so why physical activity and exercise? Because first of all, we have evidence in the literature that it can be an efficacious method to alleviate symptoms in a variety of diseases, chronic conditions outside of chronic pelvic pain disorders. We have similar evidence to a lesser extent for chronic pelvic pain disorders, but it's very promising. Specifically, if you look at the day level, for example, there's a small but statistically significant favorable effect of engaging in exercise for preventing or reducing next day pain symptoms. And this is really valuable because exercise is something that the patient can do themselves, right? They can control, they can moderate. So, and it doesn't have side effects or adverse effects that, you might experience with medications, for example. And it has other bonus side effects, right? It improves your overall health, like mortality, morbidity related factors as well. So it's a win-win for however you look at it. It also has relevance for if we want to tailor the care for these patients and determine the level of precision needed. Meaning, even though right now these N-of-1 or personalized treatment idea is all the rage, and we're all excited, and yes, they have their merit. We should stop and ask, do I really need to personalize or tailor something at the individual level, or do I just need to do the tailoring at the subgroup level? Maybe there are only 4 or 5 different tailoring, types that I need for this population. And some other things to know that make exercise especially relevant for this population is that studies suggest that about 40% of these individuals are considered low active or insufficiently active or sedentary based on the physical activity guidelines. And this should be a concern for us because insufficient activity or sedentary behavior is associated with increased risk of adverse health outcomes. So, okay. Now with that, I will move on to the methods, and we will look at the sample, the data, some of the models that we're using, and I promise no formulas. Okay, so this study, as I mentioned, comes from our ongoing NIH study that is focusing on mHealth techniques. I'm happy to chat later if you have any questions. But our sample has 76 individuals who have a diagnosis for a chronic pelvic pain disorder. And the study design includes 14 weeks of daily, self-tracking weekly questionnaires, as well as data from Fitbit trackers. So that gives us a total of almost 800 person level weeks, which equals to about over 4,000 person level days of data to work with. Now, in terms of the demographics, it's somewhat homogeneous, if you will. They're mostly employed, urban dwelling, of reproductive age. So the median age was 35. And as I said, the data sources, we have weekly questionnaires. So these are standardized questionnaires, and we like these because they are standardized, they're validated, they're clinical benchmarks. So you can use cutoff points to determine, the clinical relevance of some of your outcomes or, point estimates. And then we have the passively obtained data from physical activity data from activity trackers. Now, before, going into rolling up our sleeves and going into trying to analyze the data, first we look at visually the distribution of the data, what they look like, and also conceptually trying to form our, theoretical model, especially when you have, is the case with us, we have so many data variables available to us. So when we're forming our hypothesis, there are various predictors and various outcomes, various variables that you can use to answer your question. So we'll look at the distribution, some of which one would make the most sense. So I'm interested in this case, specifically looking at the influence of physical activity on mental health outcomes. And that is because, as I mentioned earlier, depressive and anxiety symptoms are among the most common comorbid symptoms in this population. And we know that outside of this disease cluster, exercise can be a very efficacious method to manage these symptoms. So I'm interested in seeing if the same relationship holds in this population as well. So for this one, I'm using the PROMIS Global Mental Health survey. So this is, again, one of those validated standardized questionnaires. What makes it really nice is that it's just 2 items, but it was clinically benchmarked and validated. No, in addition to that, I have some other variables that I could potentially use. I have the McGill Pain Questionnaire. So it's basically a visual analog scale asking about current pain. So how much pain you have. At the moment, there's pain interference, and that assesses the impact of your pain on your function. So are you able to carry out your day-to-day activities despite the pain? We have physical function, so you know how you're functioning physically. There's pain self-efficacy. So again, this is similar to the previous. It's saying your belief in your ability to carry out your day-to-day activities despite the pain. And then we have steps and moderate to vigorous physical activity. And in the plots, you're basically seeing the distribution. And the main thing to get out of these is that there's quite a bit of variability, right? On the x-axis, you have the weeks. On the y-axis, you have the scores for some of these. And the other thing to look at is in that table, I have the interclass correlations and then within individual variants and between individual variants. So I don't expect all of these measures to be highly variable. Some will be less time variant, i.e. they will be more time invariant, right? So depending on that, which one you want to plug into your model, you might want to be careful when you're doing that. So for example, it does make sense that, let's see, the pain self-efficacy, it is more stable, relatively speaking, right? And we know that from the literature that self-efficacy tends to be, it's not as fluctuating, you know, it does, we wouldn't expect your sense of self-efficacy to change every day. Okay, so going into our main predictor, we have, okay, I have time, just checking the time. So day-to-day variations in our physical activity predictor. So as I said, I'm focusing on moderate to vigorous physical activity. Now, why specifically that variable? Because we could have selected other ones. There are different, right? Any of you who use any of these trackers, there is light intensity, right? In addition to moderate and vigorous, you could use steps. There's sedentary minutes, like there are other options we could take. However, we use MEPA because that is the one that has been most closely associated with mental health symptoms. Whereas if I were interested in overall health, like mortality, comorbidity, etc., or physical function, steps tend to be a better measure for that, or proxy for those outcomes. So that would inform my selection. Okay. Now the lattice plot on the right is just to give you an idea. So it's a subsample of the participants' daily MEPA plotted against the 14, against how many days? Yeah. Basically the whole study period. And the main thing to get out of those is that there's quite a bit of variability, both within and across individuals. Let's see. Oh, I'm not sure. I'm not familiar with the Is this, I'm assuming that's more of a neurological or physical assessment, like somebody implements the
Yeah, sorry, I didn't mean to interrupt, but yeah, just because it's funny, that was one of our like variables in a data set from our class. And yeah, that's like it was for oncology, I think. And it was like 0 to 100 score of like, they test like
So,
walking and like gripping things. And
yeah,
but I
so
was just curious if they're like
so
really,
it's not provider, or it's not like administered. It's not
I see.
administered
So this is
by,
self-reported.
yeah, it is self-report, but
Okay,
I'll
got
say
it.
the PROMIS physical function, a lot of the PROMIS measures have been, when I said clinically benchmarked, they're often validated as, you know, psychometrically assessed and clinically evaluated against other measures. So
Yeah.
chances are the physical function was tested against some, clinician administered measure. You would just need to go in and check.
Got it. Cool.
So
Thank you.
that's usually how they validate.
Cool.
Because it does ask questions like, how well are you able to walk or, lift something,
Yeah.
yeah, like force strength, all of those. Yeah.
Cool. I know multiple people in here are in 5300, and that was one of the variables in we did it, yeah, like a brain cancer data set. So cool.
Yeah,
Thank you.
Yeah, of
Yep.
course. Very useful measures. Okay. So let's see. Okay. So I have, where's I am missing a slide. Am I missing a slide? Interesting. Okay, I'm missing, somehow my slides got confused. It's okay. So, okay, so that was a predictor. Now let's think about our outcome. Now, as outcome, I did say I'm using the global mental health because it's brief, it's easy to administer, and it has been psychometrically evaluated. So we know that it correlates also with psychiatric diagnoses and other clinical measures. So that's really nice. That's very advantageous. And similarly, you're seeing on the left side, we have a lattice plot. Again, there's quite a bit of variability, but what I did here is, in addition, I'm layering here GMH against MEPA, and I just for ease of, I guess, like visual ease, I divided MEPA. So there's below average MEPA, and then there's average MEPA, otherwise there were too many jitter points. So again, so we're seeing there's quite a bit of variability. So, we need to be able to, we need a model that will be able to handle all of this variance. And of course, we have other potential covariates, right, that we can adjust for, control for. So those will also be accounted for. Now, so let's think about it. We have daily moderate to vigorous physical activity, right? And if we're thinking at the week level, it's, 7 days of activity. And then we have once a week of these outcomes. So in this case, it's global mental health, but all of the other self-reports here are also at the week level. So basically, they're on different time intervals. What we're going to do is find a way to regress this outcome of GMH on the 7 days of data. And I don't want to aggregate into a weekly, summary. I want to be able to look at the trend. So because maybe there's a meaningful relationship, or the variation throughout the course of the week is meaningful. We don't know. And of course, we have repeated measures, right? Because each individual in our case has up to 14 weeks of data. And then, as I mentioned, there's all this, variance. So we want to be able to do that. So what do? We used generalized additive mixed models. And then there will be similar or different names or similar names that are used to describe this family of models and functions. So you might have seen and heard different ones or similarly sounding models. The chances are they all do the same thing under the hood. But the trick, basically the main trick, is that they're able to capture complex, i.e. nonlinear relationship by fitting smooth functions through the data. So what it is doing is it's taking the 7 days of data and then turning it into a smooth, right? It's using basis functions to do this. So now each of those 7 days, so each week becomes, instead of 7 discrete data points, I have 1 curve. So now everyone has up to 14 curves, and that becomes our main predictor. So now we have and when you do that, now we have the outcome on the same time interval. Now we can regress it against the 7 days of data, right? Like the model can handle that. And unlike a B or a beta coefficient in a linear regression, these smooth functions are nice because they allow change over the range of the predictor. So if there are changes in your predictor over the course of the week or whatever your time frame is, it can handle that. And in this specific models, so I'm using RStudio, Refund library, and then there's also MGCV. But I think Refund relies on, not I think, I know Refund relies on MGCV for some of its functions. So, they're both used. You can the smoothness, so how wiggly I want my curve to be, it can automatically determine for you, because otherwise that gets very tricky, especially if you have a lot longer, time frames. Like if you're looking at year-long data and how, trying to determine how much wiggling or how much noise versus signal you want to get at or you can see, that can be tricky. So that the model can do it automatically somewhat under the hood is really, really advantageous. Okay. So we did this. Okay. So now I'm using, as I mentioned, first we'll do some GAMs using the refund package, and for the R curious or the code curious, this is what the model looks like. It's using the same Elmer or LME4 or Elmer test based, modeling language. So it'll look very, very similar. I have the main, predictor. I have the covariates. I have the random effects. So that we can account for differences across individuals. And you don't have to have, so not all your predictors have to be functional. So for example, in our case, we have some baseline predictors as covariates as well. For example, we included pre-existing psychiatric diagnoses as a covariate because we hypothesized that someone having a clinically diagnosed depressive or anxiety disorder might influence the relationship between the outcome and the predictor, right? The other thing I'm doing is I'm cyclically encoding time variable. So this is natural time. So I'm also adjusting for time as well. So and in this case, it's adjusting for monthly cycles in case there are some natural, monthly cycles that could be influencing the relationship as well. Okay, and the rest of it is just very familiar. So let's look at some results. First, we'll look at some descriptives. Now, the first thing to notice, and some good practices, is to look at how our sample is doing with respect to what we know from the literature or, based on the population norms. And the promise, another advantage of these promise measures is that they have population norms, so you can compare your sample against the population. So in this case, what we find is that our population, so these individuals with chronic pelvic pain disorders, they have lower global mental health scores overall compared to the population, as well as lower physical function, which is understandable. That's plausible, and you would expect that to be the case given the nature of their disorders or their diseases. Now, the other thing was when we looked at the global mental health scores by psychiatric diagnosis, those who did not have a pre-existing diagnosis, they did score a little higher, but there was also a lot more variance in the scores. So that was a much smaller effect than you would have expected. Now, interestingly, the mean moderate to vigorous physical activity minutes was actually, it was a little higher than I would have imagined. It was 38 minutes, but this is also very there's a lot of deviation or skew, excuse me. So the median is actually a lot lower than that. So there is still a sizable portion of the sample who are insufficiently active. Okay, so this is the output or the results from the smoothing function, the functional GAMs. Now the top left lattice is the random effect. So this is the effect of the individual. So this is the variance or the variability in the outcome, i.e. the global mental health scores for each individual. So each blue dot is one person. Those gray lines is the 95% confidence interval for each individual. And the x-axis is the effect, right? The estimated effect. So as you can see, there's quite a bit of variance and interest. I guess not that interestingly, but one thing to notice, there was variance both within individual and across individuals. And this would, of course, be because these are estimated. This is after adjusting for all of those, the list of covariates and other things as well. So the scalar predictors that you're seeing on the top right, those are all the covariates that we included. The directions overall is just as you would expect. For example, the more pain somebody reports, the lower their global mental health. employed individuals who were employed were, they had higher global mental health and so forth. So that's mostly predictable or as expected. The bottom left is the output of that functional main predictor that you see. So T is time. If you think that's not very intuitive to interpret, I completely agree with you. It took us forever to kind of decode what it was trying to say, but the main thing to get out of it is there's a little bit. First of all, this is not as wiggly, and which I did expect that to be the case. You only have 7 days, so there's only so much fluctuation you can have. But what we see is that there's overall a favorable effect of moderate to vigorous physical activity on global mental health. So it's a significant average effect. So after adjusting for all these covariates, after adjusting for between person, variance and all those random effects, there's still a positive favorable effect. And there's a bit of a lag. So it's around the activity on the 3rd or the 4th day that was most predictive of the global mental health outcome at the end of the week. So there does appear to be a little bit of a delay or lag, if you will. And of the covariates, one that is of important to note is that this effect was the case regardless of a pre-existing psychiatric diagnosis. So regardless of whether or not you had a, depressive or anxiety disorder, you still benefited from this favorable effect. I will, in the interest of time, I'll very quickly do this, and then if anyone has questions. So I mentioned you can also look at steps, right? If you're interested in looking at other maybe factors that are associated with health. In comparison, for example, we want to look at the influence of weekly steps as a predictor on pain self-efficacy. So remember, this is the more time invariant outcome. So I want to understand if I can predict or estimate someone's pain self-efficacy pertaining to that past week based on their passive activity from their tracker. And this can be useful if I don't have a way of assessing this, so frequently as we had in our case. And what we find here is that it is indeed significantly predictive, but there's a lot more linearity, so it doesn't fluctuate as much. So it tends to be a bit more linear compared to the previous model that I shared. And in both cases, the current pain is predictive of, if it's a significant covariate. So it did explain a significant portion of the variance in the outcome. Now, ultimately, what we see is that moderate to vigorous physical activity is beneficial, as I mentioned, regardless of pre-existing conditions and other pain-related factors for better mood. And the pain-physical activity relationship itself might be more linear. That one, I don't have pain as an outcome here, but when you look at it, it tends to be not so fluctuating compared to some of the other variables. And the self-efficacy, the pain self-efficacy question, what we looked at with the naked eye does seem to be confirmed that it tends to be on the more stable side. I wouldn't want to, categorically call it a stable trait, but it's not as time variant. And it is more responsive to overall daily activity volume, as opposed to this very specific, subcategory of physical activity. Now, in conclusion, this is just one example of the complex interplay between health behaviors and symptom experience over time in female chronic pelvic pain disorders. And this relationship and this complex interplay is applicable to other chronic conditions as well, not just this. So even if you're not interested or not familiar with some of these diseases, you might see similar patterns in, for example, multiple sclerosis. That's another disease model that I studied a lot with, earlier in my career. So you see similar patterns as well in those conditions. Likewise, the methods discussed can be broadly applied to various research questions. So in addition to, disease models, outcomes, data variables, but also data patterns and data structure. So it is important to consider what type of, data that you're working with and how you will use those data to answer your research question, because that can enrich and augment and give you a much better answer, if you know how you're going to, tackle the data so that you can best answer your research question. Okay, and with that, I'd like to thank you for your time and attention, and I'd like to acknowledge my collaborators, my team, and those are some of the links that you can reach me from. And yeah, and that's it. And I'm happy to take questions. I think we have some time.
And you guys can put questions in the chat, or you can unmute and ask them as well.
This was great. Thank you. Very interesting.
Yeah, let me see.
I just want to say thank you for your work. This is a field that's often overlooked, I think, and I think that this is really impressive work, and I appreciate the way you talked about all of the considerations going into it. It seems like quite a holistic and comprehensive analysis, and it is like chronic diseases are very, very hard to track and manage. And like I, for example, have dealt with a lot of pelvic pain issues in my life, and it's just, it comes because a lot of the data you can capture from it is subjective, and there's no way to like objectively quantify how much pain you're in and where exactly it's coming from and what the cause is. This made me think a lot about, this made me think a lot, and I really appreciate the work. Just wanted to say that.
Well, Viviana, is that how you,
Yes.
really? Yeah.
Yeah.
Well, thank you for sharing that. Thank you. That's a very kind thought. And I completely agree. It can be difficult. And I think in both the research and perhaps the clinical world, we glorify objective measures over subjective, measures sometimes. But ultimately pain is, it's a subjective feeling. Like it is by definition, it's right. Someone's perceived. So that is very valuable as a data point. I think one of the things where we don't do a good job of is still we use, in clinical settings, they use the visual analog scale, right? Like how much pain do you have? Which if you ask the patients, they actually say, well, this doesn't really comprehensively capture my experience because what area, like I feel different types of pain in, different body areas. Or different intensities. So something that we have been working on in the lab is to devise or design a composite pain score that integrates all those different dimensions of the pain experience and see if that is a better predictor of these other, clinical endpoints so that they could be used for, whether it's diagnostic purposes or treatment response assessment. But I think, your personal experience, you're still the, the best person who knows your pain experience. So
Right. And like with that, with what you're saying, like when I was going through a lot of my pelvic pain issues, I would like talk to doctors and they'd be like, "Oh, well, it's probably like it sounds like GI." Like sometimes it's really hard to distinguish and differentiate too when pain is so, I don't know, you feel pain in one area and it kind of spreads through. It's hard to specifically locate a lot of the time too, and it's very complex. And that's why I really appreciated the models, the methodology you talked about, and the models, and addressing how this is very complex data and a very complex kind of mission to tackle. So yeah, just want to say that.
thank you for sharing. I appreciate it.
Thank you.
I have a question if I can ask like a second one.
Yeah.
It's yeah, I think like one thing that I found super interesting, it's like I said, I don't I guess work that much in healthcare, but I'm sort of analogizing it to stuff I've worked on, and um like one of the things I remember when I was like sort of data consultant for like this education in like the education field, they were sort of like, people keep giving us money for like iPads basically, and they were like, we don't need iPads, we need like other things. And so I'm curious, it might seem out of left field, but like because I know you're like your lab, part of it is like tracking people with people's pain, like with like the Fitbits, and then sort of like, I don't know, to oversimplify it, like correlating it with their self-reported pain measures, to way oversimplify it, since that's the whole goal of your talk, is not just correlation. But I just bring that up because I'm like, yeah, do you feel like the current like barrier that you face in your research, like trying to, like, every day when you go in and you're like trying to progress a project, do you feel like there's like a technological barrier, or like a barrier of, yeah, the measures or lack of measures, like that Viviana brought up, or maybe just like research? Like sometimes in my lab, actually, which was at Columbia, right? So, but it's like, I just remember thinking like, oh, I wish there were many more labs. There was like one lab at Columbia and one lab at ETH Zurich that was like doing what we were doing. And I was like, oh, I wish there were like 12 instead of one. So then, yeah, I just figured I'd say that because you also mentioned like not that many people might work on this specific field. So anyway, I was just curious, like, which of those you feel like is a barrier in making progress on this problem. Yeah.
I think that the main barrier, what a good question. I'm trying to
Sorry, I know it's like
think. No, it's a good question. I'm trying to think how to best capture how I feel. So I think, I mean, there's of course, lots to answer and lots to research, but we have a relatively good understanding, at least, as immediate next steps, what to do and how to investigate. Like we have the technology, we have the, research capacity to do all these things. I think the clinical translation tends to be one of the barriers, because once you develop these things, you need to take them into the, point of care, and you need to convince the, if you wanted to test like some sort of, at least even something as simple as the clinical feasibility of using, like we have the composite pain score that I mentioned. We first published it, I think in 2000, I don't know, 2020. So, it has been several years. But getting it in front of the providers, or like getting a large enough, sample of clinicians to use it so that you can test those aspects, I think that is one of the big challenges. And that's for a variety of reasons. Not just, oh, they're resistant and they don't want to change their methods. It could be time related, you need a lot of clearance. So I think like that translation is, and I think it's, discouraging a little bit, like, you lose steam after a while, just because of all the other responsibilities you have as a researcher. So I think that's one. The other one is, I think the measure design field, or I guess psychometrics is not a sexy topic, like nowadays, what is sexy? Like LLMs, AI, and like all those, like there's always a trend, right? Like, and if you throw in those words to make yourself look relevant. So I think, and it was RNN some years ago, then it became reinforcement learning, and then it became whatever. Like there's always a sexy word in the research world, and I guess in, tech world. So if you're not doing one of those fields, then I think you don't get as much support, even though this is very relevant. So I think getting buy-in, unless it's a big name person, and I'm obviously not a big name, you know what I mean? So I think
Yeah,
that's
that's so
really,
interesting.
we really, if you're being very realistic, and I realize I'm being recorded, so I'm trying to be,
No,
very
you're good. Sorry,
diplomatically
I put
correct,
you on
but
the
I
spot.
think
Yeah.
that's the main thing. I think it's awareness of the importance of this field.
No, I totally, that puts me of like, if you put LLMs in the proposal, like how much does that increase the probability of like getting buy-in on it? I've seen that for sure. So that makes a lot of sense, and it just helps to give like insight into the broader thing that your lab is doing. So thank you so much. Yeah, like Viviana said, I just think it's so important. Yeah.
Yeah, absolutely. Thank you for your question.
Yeah, this is very impressive work. We appreciate it.
Thank you, Dr. Parnham. Appreciate it.
I had a quick question. Just at the end, you kind of mentioned that there's like a lot of other like avenues for this research and model, and I was just kind of curious if you had any like specific predictors that you've looked at already, or like want to look at, like outside of physical activity, that you think are like particularly beneficial for patients in this scenario?
So right now, as we speak, I have a student with whom we're trying to see if we can predict flare-ups using heart rate variability. Heart rate variability, and I go a long way back. I worked with that variable for many years, but it's one of those things that are also amenable to so many other things, like so many things. You drink coffee, it impacts so it's very difficult to extract the pure, like isolate its effect. So I think it's one of the reasons why it's challenging. The reason we picked this up is because I had a colleague who actually published this very sleek, really nice model where they were able to predict flare-ups, IBD flare-ups from heart rate variability. So we're basically trying to see if we can replicate something similar for chronic pelvic pain disorder related flare-ups. So that's one. So I think heart rate variability, and there tends to be in general interest in that as a predictor. And the fact that it's again a passively collected data, it minimizes or reduces participant burden. So that's another advantage. So, but that's still work in progress.
That's really interesting. Thank you.
Let's see if we have another question. Yeah, thank you, Ash.
In the back of my head, I also just is coming from a non-data science background. I just keep thinking that we need good marketers behind you guys to get people interested in this, because it's such important work.
Yeah, no, definitely.
And if Dr. Ensari is okay with it, I will share these slides with you guys afterwards, and the recording as well.
Yes, yeah, happy to. I can send you the PDF of the slide.
That'd be amazing.
Yeah. And feel, if anyone has, questions later, they think of, feel free to reach out to me. You can email me and yeah.
We'll definitely do so. Anybody want to throw something in the chat or unmute real quick? We have a few more minutes with Dr. Ensari. We want to be respectful of yours and her time.
I'll stop the share so that you don't have to stare at my final slide.
Gives us time to write down your email address. Oh.
I actually just have a really quick question about one of the covariants you mentioned, clinical depressive disorder is something you look at. Do you have any data that separates, just wondering if you look at postpartum, given I think it was a median age that you mentioned.
Yeah.
Is
So
it
great question. So one of the exclusion criteria is recent birth. Just so we, as you also alluded to, that potentially confound or other reasons, but so none of these individuals had recently given birth. With that said, I know there can be instances where postpartum depression can last for, much longer. And I'm not an expert. All I know that it can, last longer. But so for our purposes, I'm going to guess no. But the way it was asked was if they have any psychiatric diagnoses, and then if so, what they have. Nobody mentioned postpartum depression. That was not in the free text response. That was not mentioned. So.
Thank you.
But yeah, that's definitely another very important area of research, looking at postpartum. So.
Well, if there are no more questions from the group, we will end here. And I will again send out the slides and the recording, if not later today, first thing on Monday. Thank you so much, Dr. Ansari, for joining us.
Yeah,
And
absolutely. Thank you for having me.
and as you've heard, many of us think that it's such an amazing topic. Sorry, Purna, go ahead.
Yeah, I was just thanking her. Yeah, thank you so much for this amazing work. Yeah, some work are very sensitive topics, but that need to be done. So it's very impressive. Thank you.
Thank
Yeah,
you.
thank you. Great talk.
Yeah, thank you, everyone. And it was very nice to meet everyone. All of
Yeah.
you. Thank you for your questions.
Thank you.
Bye.
Have a great weekend, everybody.
Have a
Bye.
great weekend, everybody.
Thank
Bye.
you.
Thank you.
Thank
Bye.
you.